Hello, everyone. Thank you, Dr. Gul, for a wonderful session. Now we are moving on academic session 5 by Dr. Dragan. He is from Serbia. He is a member of KTI Research Committee and a frequent presenter at congresses and at the KTI Symposium. He has been an active physiotherapist in Belgrade since 1990 and is proficient in a range of therapeutic disciplines and teaching areas including shiatsu, fascia, myofascial release, and treating discordral conflict conditions. He trained in kinesiotaping in 2005 and served as translator and lab assistant for courses in Serbia starting in 2007. Dragan has been a certified kinesiotapy instructor since 2008. Thank you, Dragan. Over to you now.
A big thank you to Dr. Ankit for managing to organize this kind of event. Now, on the beginning, I'm just gonna give you a short introduction of who I am and what I'm doing so you can get a little picture of my background. My name is Dragan. I'm a PT from Belgrade, Serbia, and after finishing high school and college for PTs, I immediately started to work at orthopedic surgeon hospital, and I worked there for a few years, and that's where I gained my experience for treating trauma in early stage. Later on, I finished some courses in different techniques to treat body manually, like Yumeiho, which is a Japanese manual therapy, and also I finished the International Shiatsu School, and during that finishing school for Shiatsu, I started to learn more about fascia and its significance. And also in 2008, I finished the TheraBand Academy, where I was learning about significance of proprioceptors and about proprioceptive training. About Kinesio, I first heard in 2003, and in 2005 I started to educate myself concerning kinesiotaping, and in 2008 I finished my education in United States for kinesiotaping instructor, and since then I'm teaching courses from kinesiotaping. Apart from all that, I also finished training in craniosacral osteopathy and biodynamic craniosacral osteopathy, and I finished first level of visceral manipulation training. So let's start with the presentations. The topic of the presentation is treating fractures and open wounds with kinesiotaping. What is specific about this is that few of these cases happened personally to me, so it is only when you meet the obstacle that you can advance, which means that the problems that I personally had were forcing me to think the ways to overcome them, and that's how I figured out a few of the applications that you will be able to see. So first case was traumatic injury. First case is traumatic injury of the left elbow with radial bone fracture on two spots, here and here. The arrows point out, and it was without dislocation. So immediately following the injury, sharp pain in the elbow was present, but at that moment full range of motion in the elbow was possible, and so that made me think that there is no fracture in the elbow. Of course, 30 minutes later, there is still presence of a sharp, strong pain in the region of the head of the radius, But unfortunately now, so 30 minutes after the initial injury, there is heavy elbow swelling, and there is no possibility to move the elbow joint in any direction. So it's stuck, like we can say, it's blocked on the 90 degrees angle. So luckily, I always, when I travel, and at that moment I was out of the country, whenever I travel, I carry with me Kinesio text tape, and so we arranged that Kinesio fingerprint was applied around the elbow in web pattern. So on this image here, you see we try to mimic the pattern. Because there was much more swelling in the elbow than on this picture. So this picture is the original picture that was taken the day after the injury. So this is the original, one of the original tapes. And so the tapes were applied on the front side, on the back side, and on the side of the elbow. But the problem was that there was no possibility to do the movement. So how did we manage to create wrinkles? Well, we managed to create wrinkles because the tension that was applied to the Kinesiotape tape was 0, and manually we stretched the tissues. And so after the tape application, in the next 10 hours, there was still presence of a strong, heavy pain, but after the tape application, the swelling wasn't increasing, which is a big thing. And also during night, I applied a cold shower a few times during the night. And in the morning, the situation changed in a better way, which means that I didn't had, while the elbow was in the 90 degrees angle position, I had no pain, and I was able to do 30 degrees of range of motion from 90 degrees to 120 degrees without pain. And so it allowed me to be functional to a certain extent. So I had only 30 degrees range of motion in the elbow, and I wasn't able to do full supination and pronation. Carrying weight in my hand was not possible. So for the next 30 days, I was doing only active movement till the point of pain. So I was just holding to the range of motion that has no pain, and every 7 days I was changing the tape on the elbow with main function to decrease the swelling. So somebody may ask why I was changing the tapes every 7 days. Well, I was changing them because as I was gradually getting more and more range of motion in the elbow. So with that increased range of motion, when I do the next application, I was able to get more wrinkles with the tapes, and that was was a big benefit to decrease more this swelling that was in the elbow region. So apart from applying Kinesiotape tape, I was also using elastic bandage 2 times a day for 60 minutes in a elevated position of the hand, and I was also using a mild pressure on carpal bones to facilitate bone healing. What does this mild pressure means is that it means that I would usually straighten the elbow to the degree that it was possible for me, and then I was just gradually leaning on my carpal bones. The idea was that this longitudinal pressure would be a stimulation for bone healing. So I was also doing static contractions of flexors and extensors, very mild contractions, but to keep the muscles active. And I was doing them in a different joint positions. So after 30 days, the swelling was gone, and but I was still not able to carry weight larger than 1.5 kilograms. Just to let you know that it was only after 5 days that I was actually, when I did the X-ray, I was aware that there is a fracture of the head of the radius, and so at that moment, so it's 5 days after the initial injury, I had two choices. Go to the doctor and apply the immobilization with the plaster, which I knew that would create contracture of the elbow joint, and I would not be able to do any manual treatment while I have my elbow in immobilization. So I decided to do the other thing, to try and fix this problem without immobilization by plaster. So I was just using Kinesiotape, and I was of course paying a lot of attention about which movements I'm gonna do. So after 1 month, the Kinesiotape was applied based on muscle testing, and muscle testing showed that biceps brachii and brachioradialis need to be taped distal to proximal, as you can see in these pictures. And also correction technique was applied directly over the head of the radius to create the effect of stabilization and fixation. And also I continued to do static contractions of the muscles surrounding elbow joint. So during next totally during these 4 months of my rehabilitation, kinesiotaping was used based on muscle testing in conjunction with exercises, and no immobilization was applied. So after 4 months I was able to load full weight on elbow, or should I say on my hand, and at the end to carry weight and to lean on my hand. And also at the end of 6 months I regained full range of motion and functionality. So once again I need to point out that the bone healed with no immobilization applied. So the second case is how can we treat kinesiotaping, or how can we treat open wounds with kinesiotaping. So here we can see on the picture that proximal interphalangeal joint of the index finger was injured with a Swiss pocket knife, and the injury was very serious because the cut went all the way through joint cartilage, and the cut was from here all the way through here. So all this tissue here was just when it was cut off, was holding on a small piece of skin here. So at that moment you gotta think fast, and I had two options: either remove all these tissues that was originally cut, or put it back and put the bandage. So I decided to go for the second version. I put the tissues that were cut off, I put it back here, and I bandaged my finger. So all this happened in the afternoon, so I left the bandage on the wound all night, and in the morning I took out the bandages, and so this is the picture from the next morning. So there is a big swelling of the whole finger as a reaction to the trauma that happened. And so I decided to, and I was only able to do 20 degrees of flexion in the proximal interphalangeal joint, and it was accompanied with a sharp pain. So I decided to try to do something about the swelling with the Kinesiotape. So fingerprint Kinesiotape was applied on the dorsal and volar side of the finger, and also along with Kinesiotape I was using specific fascia exercises to increase the mobility or should I say range of motion in my proximal interphalangeal joint. So what was specific about these exercises is that I would try to flex my finger till the point of where I feel a slight pain, and I would hold continuous contraction in that position for 3 minutes. Then I would go to opposite direction, which is extension, and I would hold my finger in that position also for 3 minutes. The intensity of contraction was 30% of my maximum strength contraction. So I was doing it every 30 minutes. And after second day of applied Kinesiotape, I was able, from only possibility to do 20 degrees range of motion, I reached 90 degrees of flexion, and at that point I regained the functionality to do manual treatments. So I was able to do my job. And on the day 7, which is 5 days after this, I reached maximum joint flexion in the proximal interphalangeal joint. So the only time when I felt pain during flexion and extension was at the end range of motion of flexion and extension. So after 3 weeks from injury, the cut wound was healing, but in the exact area of the injury I had no sensitivity in the injured tissue, and the tissue itself was thicker than the surrounding skin. And when I do total extension in proximal interphalangeal joint, no wrinkles were showing up. So when the wound healed, I was able then to apply Kinesiotape fingerprint directly over the scar tissue, with the intention to separate tissue layers and to gradually get the wrinkles on the skin. So tapes were applied in a period of 4 weeks, and I got wrinkles, so wrinkles were visible, but also my sensitivity in the area of scar tissue was back. So concerning these open wounds, I regained full functionality of index finger. Next case is again fracture. Traumatic injury of the right distal interphalangeal joint happened on a volleyball match, and after X-ray, diagnosis was a avulsional fracture of distal phalange of the little finger. So at the moment when the injury happened, I thought that it's not a fracture, and so what was present was very sharp pain and swelling, and also visible hematoma in the nail region. So 2 hours after injury, Kinesio web application was applied to decrease swelling, and also immobilization was applied with a piece of plastic and elastic bandage. But after 2 days, Kinesiotape was needed to be removed because I had stronger pain, and also there was hypersensitivity in the region of the fracture. So I tried for next few days to just use the immobilization, but you know, when you have a immobilized finger, uh, you cannot find normally because your proprioception is not normal anymore. So I thought, how can I try to regain my proprioception and keep the immobilization? And then the idea came to try to use Kinesiotape, certain correctional technique, to keep the segments in a correct position, and that's what you see here. And the applied tension was 100% from here to here, and also here 100% was used because the purpose of this tape was to try and press this fractured fragment on correct position. And I did regain the full proprioceptive information in injured segment, and I was even able to bend or to do flexion in the proximal interphalangeal joint without compromising the position of the distal interphalangeal joint. But since the tension that was used here was 100%, after 7 days of wearing this correction taping, it was too much for skin to bear, so it became very unpleasant, and I had to remove these tapes that were here. So in the meantime, I consulted with the orthopedic surgeon and the plastic surgeon, and the orthopedic surgeon suggested immobilization. And I said, of course, yes. They applied the immobilization, but it was applied too tightly. So my pains become even more bigger in the region of the injury, and the skin changed color. So it was clear to me that there is stasis, or should I say that the blood flow is compromised, so I removed the immobilization. So then also plastic surgeon that was consulted, he suggested the fixation with metal needle, and it was applied, let's say, 3.5 weeks after the initial injury, and I kept it for the next 6 weeks. So here you can see how the finger looks after the surgery, and so after the surgery I had very hard pains and swelling. Why I had hard pains? Well, one of the reasons was that as you can see on the picture here, there is also present subluxation of the distal phalanx, and you can see on the picture before surgery that there is no subluxation, so that can be one reason. And also the needle probably injured one of the blood vessels, and there was very big swelling in the region of the distal phalanx and the middle phalanx. And unfortunately, first 2 days after the surgery I couldn't do anything about swelling and pain because the finger was bandaged. But after 2 days, I went to check in on the surgeon, and bandages were removed. So I was able to then use the cryomassage to decrease the pain, and also use the elastic bandage to decrease the swelling of the finger. I was not able to use the kinesiotaping because there was big sensitivity of the skin. Even mild touch on the skin was very painful. So I was forced to use elastic bandage. But what I didn't like was how my finger looked when I take off the elastic bandage, and this image, second image from the top, shows how the skin is after taking off the elastic bandage. So I was not able to use the Kinesiotape, but I was thinking, how can I use the elastic properties of the Kinesiotape without actually using adhering the tape, Kinesiotape to the skin. So then the idea came to create something that I called Kinesio sleeve. And the picture that is third from the top shows how my finger looks when I take off the elastic sleeve that you see on the bottom picture. So you can see the difference in the skin wrinkles with the elastic sleeve and with the Kinesio sleeve. But what is important here is that so Kinesiotape sleeve, I just pull it to the top of the finger and I take it off. And it's important to know how to make it, and of course how to do the right measuring to have the appropriate elasticity forces that this sleeve is creating. So this is how elastic sleeve looks, and so it's made out of two tapes. They don't have to be different colors. I just used different colors so that it's easier for you to figure out how it was made. So this red piece of tape is adhered to this blue piece of tape. Then it's wrapped around the healthy finger. So pay attention, it's wrapped around the healthy finger because that is our goal. We want that amount of elasticity to work on the injured finger or swollen finger. And then this part is just when we wrap the tape around finger, this part is used to glue these two pieces together. So here you can see how this Kinesio sleeve looks before actual implementation on the finger. So aside of using a Kinesio sleeve, I tried using splint that you can see here, but I had it modified because this opening that you see here is not on the original splint. I made it so that I can put this piece of rubber and try to make it create a compressional force on the fractured segment. So just with the idea to try to increase the bone healing. And actually I tried to use it, but I wasn't satisfied with its effect. So here you have comparison of using Kinesio sleeve versus Kinesio versus not Kinesio but versus splint. So if we talk about reducing swelling and better skin wrinkles and better proprioceptive information, then Kinesio sleeve is better thing. But if we talk about providing protection from external forces, like when you hit your finger in something, then Kinesio splint provided better protection. But so only when I go outside of the house I would use sometime a Kinesio splint, but most of the time I was using Kinesio sleeve. Also I used a low frequency magnet that I held 2 times a day for 1 hour, and I also applied comfrey gel 2 times per day. So 6 weeks after the surgery, the needle was extracted, and X-ray showed that the bone started with the healing. And 1 month later, I also did another check X-ray, and it showed complete bone healing. Of course, the problem that I had later was a big contracture of the distal interphalangeal joint, but initially, since I had problem of these two segments healing, that was the priority for these parts to heal, and then later we would deal on with the contracture. So in all these three cases, kinesiotaping was applied during different phases, from early trauma phase to later phases of recovery. And in case number 1, which was the elbow injury, in the early fracture phase, the kinesiotaping proved as a very efficient modality to stop swelling and decrease pain, and of course increase range of motion. In later stages of recovery, it was helpful in decreasing tensional forces in the region of the fracture that were caused by elbow flexor muscle groups. In case 2, fractures, which is the injury of the little finger, it was very efficient in replacement for immobilization for 7 days, and at the same time it allowed free range of motion in proximal joint and full proprioceptive information. Kinesio sleeve proved as very effective to decrease swelling in a situation where we have a hypersensitivity of the skin, but we want to use the benefit of the elastic forces that Kinesiotape creates. In the case of the open wound application, of Kinesiotape text tape close to the wound helped in the faster wound healing, and very much helped in getting functional range of motion in proximal interphalangeal joint. Later, it also helped to regain sensitivity to the injured tissues and mobility of the underlying tissue layers of the injured part of the tissue. So here we have another patient. This is not me, but it's my sister that had this accident. So she injured little finger of her right leg, and X-ray showed fracture of the proximal phalanx with very big dislocation, as you can see right here. So the orthopedic surgeon performed reposition of the bone and did fixation with a cotton ball and athletic tape, which is actually the classic orthopedic fixation when the segments are repositioned, and that's classical orthopedic reposition for this kind of injury. So patient was advised to apply elevation and cryopack. Immediately pain and swelling were present in the area of the injury. So second day after the injury, athletic tape and this cotton wool immobilization were removed, and the immobilization with kinesiotaping was applied, which you can see here, and application to remove swelling in the area was also applied. So why was this piece of tape put here instead of cotton wool? Because I wanted her to be able to do cold showers few times a day, and if you have a cotton wool piece there, if you wet it, it will lose its functionality, and its functionality is to keep this fracture piece of bone in a correct position. So this piece here is made of rolled Kinesiotape tape, and it was very good because when you do the cold shower, and it will dry, but it will not lose its form and functionality. And so very fast after this application, there was a decreasing of pain and swelling, and the patient regained the ability to walk without pain. And of course she was in a possibility to use cold showers of foot multiple times during a day. Which is very significant because the date of the injury was 6th of June, and at that time we had very warm weather in our country, and that heat wasn't very good for this injury and for the swelling. So 48 hours later, different application for swelling was applied, and modification of the original immobilization application was also applied, and both were very successful. During next 3 weeks, both of these applications were reapplied every 5 days. So after the 3rd week, Kinesiotaping immobilization was removed, and the patient was able to stand on her fingers. Since it was hot summer period, the swelling of the foot was still present, so for next 25 days application for swelling had to be applied, and after 45th day swelling was gone and patient regained full functionality. Next case is a patient of mine. So in January 2019, patient injured knee while skiing. So X-ray showed a fracture of the plateau of the tibia that was later treated surgically with osteosynthesis. Patient was immediately after surgery discharged home, and we were lucky that he was discharged with orthosis immobilization of the leg. Why were we lucky? Because he was allowed to shortly remove orthosis while exercising, and we started with the exercises on the 2nd day after the surgery. For the exercises, proprioceptive training exercises were applied to increase stabilization of and the strength of the musculature of the hip, knee, and the ankle. And what is important to say that the flexion of the knee was contraindicated, or should I say forbidden, for the next 45 days. So apart from doing proprioceptive training exercises, fascia bodywork technique was applied to increase the mobility of the tissues above and below knee area. And as the wound healed and bandages were taken off, I was aware that there is a hematoma in the region of the backside of the thigh, backside of the popliteal fossa, and also there was a present swelling above in the region of the kneecap. So kinesiotaping was applied in this region of the backside of the upper part of the thigh. Fingerprint tape was applied with paper of tension. And the tissues were, since there is no flexion in the knee, tissues were stretched manually by a physical therapist. And so here below you can see the area before taping. This is the taping, and 48 hours after taping, you can see that wherever tape was applied, there is a decrease of hematoma. So as I said before, kinesiotaping fan application was applied in the region of the upper and middle part of the patella. Paper of tension was applied, and again tissues were stretched manually by the hand of the therapist. So after 48 hours I took off the Kinesiotape tape and reapplied the tape in both here, and also applied tape in the popliteal fossa. And pictures here show how the area looks 48 hours after taking off the second taping. So the effects of the kinesiotaping were clearly very visible. And also the tape here on the knee region was reapplied, and you can see it here with the orthosis that the patient was able to wear orthosis. The tape's on, he didn't have any problems. So after 2 weeks, when the skin in the area where the screws were applied was healed, the patient had pain in that region where the wound was, and so corrective application, space correction, was applied in the entry point of the screws, and tension applied was 30%, and I was using fingerprint tape because the intention was to decrease the possibility to irritate skin, and also because it affects the layers of the tissues that are more closer to the skin surface. So after 45 days the bone healed, and this is the control x-ray, and the orthopedic surgeon allowed 20% weight bearing, and he allowed knee flexion, and immediately that first day, which is 45th day after the injury, but that's the first day when the patient was allowed to flex the knee, the patient was able to do 95 degrees of knee flexion on the first day, and that significantly improved the recovery, because only after 10 days after day 45 we got full knee flexion. And those of you that work with adhesions and contractures, especially with the knee injuries, and with the patients that have knee in a prolonged immobilization, know very well that the main problem that we as PTs face is the contracture of the knee and impossibility of the patient to do knee flexion. So in this specific case, I can say that proprioceptive training, fascia bodywork techniques that were applied every day, along with Kinesiotape tapes that were reapplied every 5 days, sped up the recovery from the beginning, and also prevented adhesions, improved tissue mobility, decreased swelling, and brought patient to full functionality much faster. Thank you. If anybody has any questions or wants to consult with me, this is my email and this is my phone number.
Putting you on live.
Okay. So can I start answering?
Yes.
Okay, so first question was which one is more effective, taping or plaster in fracture? Because taping we have to change the tape again, and the plaster can last longer. So first of all, my case studies or my personal experience is just to show people that sometimes, based on your personal evaluation, we can use kinesiotaping in conjunction or to treat fractures. But that is not to say don't use plaster, use kinesiotaping. The benefit of not having plaster but maybe using the Kinesiotape to help body heal from the fracture is that there is better blood flow with kinesiotaping. Secondly, we can treat the tissues starting from skin to down to deeper tissues. We can treat them and mobilize them, and by that we prevent adhesions that if not treated will create contractions. So in some cases, of course, we need plaster because the function of the plaster is to keep the bones in a correct position so that they can heal perfectly, or so that they can heal. But in these few cases that I had, so in the elbow case, of course, I didn't plaster because I didn't want to have elbow contracture. But I needed to be very careful with every move that I do with my body. So I was doing every move very slowly, and I was staying in a just pain-free range of motion. So the swelling was a big problem, and so let's say that you have swelling after fracture and you have a plaster, you cannot affect swelling. So in most cases, if you have plaster and swelling, you will have indurated edema when you take off plaster. I had a patient that had a Achilles tendon rupture, and he was in plaster, which is quite let's say conservative method to treat that kind of injury. And after he took off plaster and came to me, the tissues were very indurated, which means that they were hard as a rock, and there was no movement of tissues, there was no mobility of tissues, and so he had no movement in the ankle joint. So when he took off plaster, then I had to apply kinesiotapes to soften the indurated tissues. So to answer the first question, which is more effective, it depends on the patient, on his situation, and in my cases, Kinesio was very much effective, but it depends on the case to case. So it's based on your individual evaluation. The point is learn from my experience. So the point of me sharing my cases with everybody is that you can see the situation or fracture problem from different angle because let's say the problem with fracture is we don't just need for the bone to heal, we need for the blood vessels to start working again, and we need to decrease hematoma and swelling, and we need to somehow prevent muscles, neighboring muscles from adhering one to each other.
Dr. Dragan, sorry to interrupt you because we are running short of time. So,
okay.
For I request other viewers, they can post the comment, they can post their questions in the comment section, and Dr. Dragan will is going to answer it personally on the comment section. And sorry to interrupt, and sorry for this because we are running short of time. So
no problem.
yeah,
I will answer in the comment section.
Yes, Dr. Dragan, thank you so much for your valuable information and the knowledgeable topic. And thank you so much for coming up and accepting my invitation for it.
Yeah, thank you. Bye.
Thank you.